Bismillahirrahmanirrahim. This session is about the heavy menstrual bleeding. And this case usually comes as a long case, but it can also come as in stations as a simulated patient task. So you must know all the options according to the NICE guidelines. If she is having heavy menstrual bleeding without fibroids, she is having only dysfunctional uterine bleeding or bleeding of endometrial origin or due to adenomyosis, then what are the options? And if she is having fibroids, then what are the options? These options, they must be on your fingertips. So we will discuss the scenario and then I will tell all the options according to the NICE guidelines. So this is a simulated patient task, and you are the fourth-year resident in the gynae clinic, and you are about to see Mrs. Avda, a 35-year-old woman. She is para 2. She is referred by her GP for heavy menstrual bleeding. The GP has ordered some blood test and scan. Her hemoglobin is 8.5. Pelvic ultrasound is normal and pregnancy test is negative. And your task is that you obtain a targeted and relevant clinical data, explain the results. You will outline and justify a management plan and establish and answer the patient concern. So first of all, we must know the etiology of the heavy menstrual bleeding, that it is palm queen. Palm is the structural causes and queen, they are the non-structural causes. So palm stands P for polyp, A for adenomyosis, L for leiomyoma, and M is for malignancy or hyperplasia. And queen is for non-structural causes. C for coagulopathy, O for ovulatory disorders, and E is for endometrial pathologies. I is for iatrogenics, like she is taking some drugs like anticoagulants, and N is for not otherwise classified. And this picture, it indicates the classification of the fibroids. Here you can see grade 0 is pedunculated or intracavitary, okay? And grade 1 is less than 50% intramural, okay? And grade 2 is more than 50% intramural. Grade 3 is it contacts the endometrium. So it is less than 50% intramural, it is more than 50% intramural, and it is whole intramural, but it is making a contact with the endometrium. And grade 4 is intramural, grade 5 is more than 50%. It is intramural, but it is subserosal, okay? And this is subserosal, but less than 50% intramural. And grade 7 is, it is subserosal pedunculated, and grade 8 is others like cervical fibroid or parasitic fibroid. Okay, so this classification you may be asked in a structured discussion or in the MCQs. So how will you start this session? You will introduce yourself, you will make a rapport, you will confirm the aim of the consultation, you will set your agenda, and the history of heavy menstrual bleeding is very, very important. This is the history that you will ask in the long case, in this, if you face a simulated patient task, or if you have a structured discussion task, you can tell that these points I will ask in the history. So first of all, you will ask that you tell me more about your bleeding? When did it start? How heavy are your periods? How many pads you soak in a day? Any history of passage of clots? Any history of dizziness or easy fatigability, which will indicate that she is anemic? Is it affecting her quality of life or not? Any bleeding in between the periods? When was the last period? Any postcoital bleeding? Any associated pain or abnormal discharge? Okay. And have she tried any treatment or not? And is she up to date with her cervical smears? Then you will ask about obstetrical history. Obstetrical history, has she ever been pregnant? What were the mode of deliveries? In this scenario, she was having previous 2 cesarean section. Okay, then her sexual history. Is she using any contraception? Any medical problems like diabetes, hypertension? And if you are planning to give her combined oral contraceptive pills, then you will rule out the contraindications of the combined oral contraceptive pills. Then any surgery other than cesarean section. Then drug history, you have to ask specifically about anticoagulants, hormonal treatments, and tamoxifen. Okay. Then social history is very important. Any family history of cancers, of endometrium, ovary, or the breast cancer, any history of bleeding disorders or the clot formation. So all these points in the history you will ask from the patient. Then you will explain the results to the patient that I have confirmed the name, age, and the hospital number. And your blood test show that pregnancy test is negative, but your blood levels, they are low. And you will explain that why these blood levels are low, because you are losing much blood every month, and this explains the dizziness. And for this, I would like to put you on iron tablets to build the hemoglobin. Along with this, you will tell that your ultrasound is normal. There is no structural abnormality on the ultrasound, and bleeding is most likely due to hormonal changes that is causing heavy menstrual bleeding. Okay. In this way, you will explain her that although the ultrasound is normal, but this bleeding is most likely due to the hormonal changes. Okay. Then what are the management options? These management options I will explain to you according to the NICE guidelines, and you can fit all these options according to the given scenario. So the management of heavy menstrual bleeding in every woman, it will depend on the preferences of the woman. Either she is having any comorbidities, is she having any fibroids or not, and what's the size of the fibroids, what are the numbers of fibroids, and what's the location of the fibroid. Is she having any polyp or not? Along with this, any endometrial pathology or adenomyosis. Then the first column we will discuss that if there is no identifiable pathology and the fibroid size is less than 3 centimeter, or she is having suspected or diagnosed adenomyosis, then what are the management options? Like in this scenario. So first of all, if she is having normal uterus, and if she is having fibroid, but the fibroid size is less than 3 centimeter, or she is having suspected adenomyosis, then what are the options? First line option in this case is LNG intrauterine system, that is levonorgestrel intrauterine system, or Mirena. If she is having no identified pathology and the fibroid is less than 3 centimeter, which is not causing distortion of the uterine cavity, she is having suspected or diagnosed adenomyosis, then the first line is levonorgestrel intrauterine system. And along with this, we will tell her that it is a T-shaped device that is coated with the hormones. It is placed inside the uterus, and it will control your bleeding, and it will also act as contraception. It will stay there for 5 years. But it can cause irregular bleeding during the first 6 months, headache, and the breast tenderness. Okay. But if the levonorgestrel intrauterine system is declined or it is not suitable for a patient, for example, if she is having a history of breast lump or breast cancer, then we will not give her a levonorgestrel intrauterine system. Then we will consider non-hormonal treatment like tranexamic acid and NSAIDs. And with tranexamic acid and NSAIDs, we will tell to the patient that it will reduce the flow, and it will be taken only during the bleeding days in a dose of 500 milligram 3 to 4 times a day. And it is effective in 60 to 70% of the women. But we will also tell the side effects, that it can cause stomach upset, and we will stop after 3 months if you are not responding to this treatment. Okay. So with each option, we will tell the pros and the cons. We will tell the option, we will tell the advantage and the disadvantage. And if there is no response, then we will move to the next option. Then among the hormonal options are combined oral contraceptive pills. They reduce the bleeding by 30%, and side effects are mood changes and the headache. And the second hormonal treatment option is cyclical oral progesterone, that is norethistron, and it is given cyclically from 5th to 26th day of the cycle, and side effects are bleeding and the bloating. So briefly, you will tell the option, you will tell the advantage, and you will tell the advantage and the disadvantage. Then after this, you will tell her that if treatment is unsuccessful or she declines pharmacological treatment or her symptoms are severe, there are three things. Treatment is unsuccessful or she declines pharmacological treatment or she is having severe symptoms. Then we will consider referral for investigations to diagnose the cause. For example, we can do the hysteroscopy to evaluate the endometrial cavity, or we can offer her alternative treatment choices that includes pharmacological options that are not already tried, like if she has tried the combined oral contraceptive pills, now we can try the oral progestrogens. Then we can offer the surgical options that include second generation endometrial ablation. We will tell her that we will pass an instrument into the womb and that will destroy the inner layer of the uterus. But it can cause discharge, crampy abdominal pain, and there is risk of the procedure, and pregnancy is not safe after the endometrial ablation. These side effects we can tell. And as a last resort, there is hysterectomy. So this is the first block where we will explain that if she is having normal uterus or if she is having suspected adenomyosis or if she is having fibroid but the fibroid size is less than 3 centimeter and it is not distorting the uterine cavity, then the first line is Mirena. And if the Mirena is not suitable or she has declined Mirena, then we can give her non-hormonal treatments that includes transamine and the NSAIDs. And among the hormonal treatments, there are combined oral contraceptive pills and the oral progestrogens. But if this treatment is unsuccessful or she declines pharmacological treatment or symptoms are severe, then we will do further investigations to diagnose the cause, and then we can offer her other pharmacological treatment that are not being tried before, or we can offer the surgical options, and surgical options in this case, they are endometrial ablation or the hysterectomy. Okay. Now we come to the second block. Before this, we can discuss about the endometrial ablation. That patient can ask about it. About the endometrial ablation, we can tell her that it's a day case procedure that destroys the lining of the womb to stop the bleeding, and it is an option if you don't want to get pregnant. But before the procedure, we will take the vaginal swabs to exclude the infection, and we will take the sample from the lining of the womb to exclude any cancer. In this scenario, she was having previous 2 cesarean section, so we will need to do a scan to check the scar. And after the procedure, you must use contraception because if you get pregnant, it will be high risk for you and the baby. So in this way, we can explain her about the endometrial ablation. So in a patient who is having previous scar, care will be taken because it can cause damage to the scar and uterine perforation. So now we come to the second block. What's the second block? Second block is the treatment of heavy menstrual bleeding in women who are having fibroids that is 3 centimeter or more in diameter. Okay. So first of all, we will consider referral for additional investigation and we will discuss the treatment options. So first line treatment is we will offer transamine or NSAIDs while investigating, and definitive treatment options, they are being organized. We will advise to continue as long as they are found beneficial. Okay, and the further treatment, it will depend on the size of the fibroids, location of the fibroids, number of the fibroids, and severity of the symptoms. And we will consider the following treatments. These treatments include pharmacological, uterine artery embolization, and the surgical treatment. Okay. Among the pharmacological treatments, non-hormonal treatment are the transamine and the NSAID. And we can explain to her that they reduce the bleeding, but they can cause stomach upset. And if you don't respond to these treatment after 3 months, we will move to the next line of treatment. And among the hormonal treatment that are being used in a patient with heavy menstrual bleeding who are having fibroids, they are ulipristal acetate, but it can cause liver injury and it is not available in Pakistan. And we can use levonorgestrel intrauterine system if the fibroids, they are not distorting the endometrial cavity, like we have discussed the grading of the fibroids. If they are intramural, if they are not distorting the endometrial cavity, we can use the levonorgestrel intrauterine system. But if she is having submucosal fibroid, then we should not use levonorgestrel intrauterine system or Mirena. Rather, we will go for hysteroscopic removal of the fibroids, and then we can put the Mirena. The next is combined oral contraceptive pills, and the other option is cyclical progestrogens. Okay, then this is the difference. Uterine artery embolization. In a patient who was having fibroid less than 3 centimeter or the normal uterus or suspected adenomyosis, after the pharmacological treatment options, we were giving the option of endometrial ablation. Okay, but in a patient with fibroid, we are giving the option of uterine artery embolization. Okay, so we will pass the certain particles into the uterine artery, and that will reduce the blood flow to the fibroids, and it will shrink the size of the fibroid. But the side effects can be there. There can be persistent vaginal discharge, nausea, vomiting, and the fever, and there can be non-target embolization. And among the surgical options, in a patient with the fibroid less than 3 centimeter, we have discussed the option of hysterectomy only. But in a patient with fibroid, we can do myomectomy with or without preoperative use of GnRH analogs to reduce the size of the fibroid. They will shrink the size of the fibroid, but they make the plane of cleavage difficult. And it is the best option for women who are trying to conceive. And then as a last option, we can do hysterectomy. Definitely if the patient has no desire for fertility. So these options you will choose, you will decide according to the individual patient. And regarding the ulipristal acetate, these are the some points you must know. You can be asked in the MCQs or in the structure discussion that ulipristal acetate, it can cause serious liver injury, and we will discuss the benefits and the harms, and we will educate the patient so she can recognize the sign and symptoms of the liver injury. We will monitor the liver function test for the first 2 treatment courses, and then if ulipristal is used for intermittent treatment in women who are not eligible for surgery, for example, where the risk of surgery they are more and the benefits are less, or if she declines the surgical treatment, then we will offer 5 milligram for heavy menstrual bleeding and fibroids of 3 centimeter and hemoglobin is 10.2 gram per deciliter or below. Okay, we can use 5 milligram up to 4 courses. And we can consider 5 milligram up to 4 courses for heavy menstrual bleeding and fibroids of 3 centimeter or more, and HB is above 10.2. Okay, so this is the uh, difference between that. In patients with the fibroids 3 centimeter and HB is less than 10.2 or below, we will offer her. But if the fibroid size is large, it is 3 centimeter or more, and the HB is also normal, then we will consider, we will not offer. Okay, this is the second option, but this is the first option. This is the wording of the NICE guideline. Okay, so we will explain the effectiveness of the pharmacological treatment for heavy menstrual bleeding, and we will tell her that it may be limited if the fibroids, they are more than 3 centimeter in diameter and HB is above 10.2. So what they are trying to say, that it is more effective in patients who are having fibroids of 3 centimeter or less and HB is 10.2 or below. Okay. So, but there is limited evidence in patients who are having big fibroids and their HB is normal. Okay. So this is all about heavy menstrual bleeding. If you are having any question, you can ask. Thank you very much.